MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt, Chief Innovation Officer at the American College of Cardiology. During each show, we talk with the guest about the latest in innovation in digital health, biotech, and healthcare, with a focus on clinicians and technologies that will be game changers. Dr. Bhatt and I co-authored the 2021 Springer Healthcare Innovation Technology for Cardiovascular Medicine, Telemedicine, and Digital Health. Be sure to check it out. When I'm not here, I see patients in the VA emergency room, urgent care, and hospital setting part-time. And I also, have a research appointment where I'm bringing on digital clinical trials. So lots to talk about there up and coming. MedTech Insights is a live weekly talk show where we love interacting with our audience. So please be sure to post your comments or questions for us in the social feeds, which are on LinkedIn, YouTube, Facebook, and we'll incorporate them into the show, post them up, make sure that we address them. We'd love to know who you are, where you're watching from, and what you're working on. As a reminder, all shows are recorded and available after the fact. It's a little confusing, so I've clarified it now. It's on YouTube under Vanguard.Health or my personal LinkedIn handle, Jennifer Joe MD, and also on Ami Bhatt's Twitter and Facebook. Remind me what your Twitter and Facebook handles are.
It is at Ami Bhatt MD for the Twitter, and the Facebook is the personal Facebook, but I think those who have it already have it. So that's good.
Wonderful. So what are we talking about, Dr. Bhatt? The massive ACC, American College of Cardiology, annual conference just came and went. All other specialties are always envious of this.
It was phenomenal. It was phenomenal. We were the first to go virtual, and sadly to do so, many years ago. And now we were really proud, therefore, to be the first to come back. It was there's the vibrancy of humans being together again. You couldn't have created this kind of spirit in any other way, but towards the end, if you will, of one version of COVID and the beginning of maybe a lifelong different version of COVID, for what it's worth. But it was really great. The amount of innovation there was just incredible. The innovation member section created this amazing future hub, which was where we had talks and lectures and companies come, and students ranging from, med students, nursing students, all the way up to those who are training or in practice, talking with each other about what they wanted to do, how they could innovate. And you really saw how the past 2.5 years of COVID have made people realize that we can do things differently. We can move faster. And so, it is really our healthcare revolution, if you will, that is happening. And you could feel that. So that was fantastic. We have a lot coming up though, Jen, and we have a great speaker today. So I want to make sure to have time, but coming up, so we have the Cardiovascular Transforum, which is coming up this weekend in Atlanta, followed by next week. In 2 weeks is AI Med out in San Francisco, where Daniel Kraft, our guest from today, will also be a keynote speaker along with me. Excited to be there with Anthony Chang and all the great people he pulls together. Before that, in Boston, we have the American Telemedicine Association, and you are going to be a judge there, I believe, in Boston, May 1st and 2nd.
Yes, well, I've already been a judge. So we have a Telehealth Innovators Challenge that we host, and we've already gotten some really interesting submissions, and I was part of that judging crew. So very excited to see the finalists pitch off, and also ATA live and in person in Boston.
That's going to be fantastic. We also have a few other things. We have the Exec Women's Conference coming up in Boston. That's going to be in June, so we'll tell you more about that later. And then we have the Convergence Forum, right, Jen, in May as well.
Yes, very exciting. Dr. Bhatt and I will be there live together. It doesn't happen very often these days. We're both zooming off in different directions.
That's right. Or just zooming, one or the other. That's right. Excellent. Well, I think one of the exciting things and coming off of ACC and thinking about kind of the healthcare revolution that's happening and how things are changing is to have people like Dr. Daniel Kraft with us today. So we're going to spend the whole half hour with him. It's going to go by faster than anybody wants. Daniel is a Stanford and Harvard trained physician scientist. He's an inventor, entrepreneur, innovator. He serves as the chair of the XPRIZE Pandemic Alliance Task Force, and he's got 25 years of experience in clinical practice, biomedical research, and healthcare innovation. He was a faculty chair for medicine at Singularity University since it was actually begun in 2008, and he's the founder and chair of Exponential Medicine. The great thing about thinking about exponential medicine is Dr. Kraft has been saying since before the pandemic, this one step at a time thing that we do in medicine, we need to think bigger. We need to think of where we want to be. And that's the only way we're going to get there bigger. And so exponential medicine really explores convergent, rapidly developing technologies, their potential in biomedicine and healthcare. And so it's been really great to be able to watch him over the past decade and a half do this. Daniel's also a member of the inaugural class of the Aspen Institute Health Innovators Fellowship. He's a member of the Kauffman Fellow Society. He has several TED and TED Med talks, some recent ones that even address COVID and how COVID has helped digital health change. So strongly recommend that you look him up there. He's published in many journals. If you look up Nature or Science, you will see that. And he's now involved in Digital.Health and has also recently founded in telemedicine. And he'll tell us more about that. Also want to say a huge thank you to Daniel. So he is an avid pilot, but he did serve in the Massachusetts and California Air National Guard as an officer and a flight surgeon, actually with F-15 and F-16 fighter squadrons. He's also done aeromedicine space research with NASA. I could probably do this for the rest of 30 minutes, so I will stop there. But most importantly, perhaps, he is a good friend. He is a good human. And somebody who really sees the potential for where healthcare can go. He saw it before, and now everybody else sees it along with him. So why don't we go ahead and bring on Dr. Daniel Kraft.
Is it working? Hey there. Good to be with you.
There you are.
All right.
Hello.
Technology works.
Great to have you with us. And so you're coming to us from home with the parents.
Live from Silver Spring, Maryland at the family homestead where I moved when I was 8 months old from London. So it's good to be home. Came here for the Passover holidays. And last month I've been in Dubai, Mexico, Miami, San Francisco, Vancouver for the DEN conference and here. So I'm looking forward to getting home after a little bit of travel.
Oh, that is so true. Well, thank you for being with us today. I forgot to say the two other things, Jen, that Daniel and I have in common. Both moved into the East Coast from London originally. So, neither one of us retained our British accent, sadly. So there's that. And then the second is Dan, you were med peds, right? Here at Harvard.
Yep. I decided, why just do 3 years when you can do 4 years of fun? So I did med peds at Mass General and Boston Children's. And I think we met when I came back to do like a little mini grand rounds for the med peds residents that you had coordinated. And it was interesting. This is like 5 or 6 years ago. Still some of that old mindset, like where's the 10-year double-blinded placebo-controlled trial for that app? Kind of the MGH way. So
it's it's an interesting. So that was actually already a decade ago. Will you believe it, Daniel? I think that was a decade ago that we brought you. It's been the first time that we brought you, and it's amazing because we see the change that happens in medicine. And interestingly, it happens slowly, and then COVID happened. And all of a sudden things start to accelerate. So maybe we have so many questions that are coming in and so many questions we want to ask you, Daniel, but maybe we can start with, we talk a lot about data on the show. And we talk about the digital health data. We talk about individuals and kind of the data that they're following from wearables, right? And what that looks like. And then there's the data from science that comes in. I would love your thoughts just on how do we pull all these streams together in a way that healthcare will get on board. And maybe we can orient today's talk in that direction. Jen, does that sound good to you too?
More data. Yeah, of course. Why not?
Speaking of data, I've got this favorite cartoon that was drawn by a talented artist at my Exponential Medicine conference. We're talking about data and healthcare. And there's a cartoon of a doctor examining a patient. He says, just as I expected, you're generating too much data. Because I don't think any of us want more data. Data might be the new oil and all those buzzwords. But what we want is the actionable, personalized insights and knowledge, or translation of data to insights, and then to be able to translate that from something published in New England Journal to the bedside or the website, which traditionally takes 17 plus years. At least I want to find out where that quote came from. But there's obviously been this big gap, and COVID did accelerate learning. So whether it's how to manage a patient in ICUs, or run virtual clinical trials, or set up new forms of diagnostics and hospital to home. So data is a bit of a so what, unless of course it fits into the workflow of us overwhelmed clinicians, and it's aligned with incentives and other pieces. So I think there's this big opportunity to go from exponential data to insights and knowledge that are translated again at the point of care, and the point of care is changing. So and the other big picture is that we've shifted in the last decade or so. We're still pretty much stuck in our sick care model, very intermittent data, usually only collected in the four walls, and that leads to our sort of reactive mindset to one that's starting to be more continuous. I've got my Aura ring and my new Circle ring and my.
I'm going to comment on that. There's a number of rings going on there. Yeah.
Yeah.
But, and well, just because you're like, hey, I don't trust this one finger to give me a good data point, I want 2 other fingers.
Well, it's fun to compare and tell. They can all tell me how badly I'm sleeping, right? Especially with jet lag. But it's, again, the challenge is still this data still doesn't readily convert and connect to you as my cardiologist or nephrologist. I mean, I can connect for a couple of years to my primary care doctor at Stanford, but what does he do with my Fitbit data? And so I think what's getting interesting with is the data insights element. You've got platforms like All of Us from the NIH, the baseline trial coming out of Verily, where we'll start to make sense of the digital exhaust and hopefully put it into really personalized, actionable context. And I guess what gets most interesting is for each of us to have our own sort of baseline and understand when changes are happening and picking up problems early and integrating that into prevention, diagnostics, and therapy.
That's excellent. So, we talk a lot about going from what we call reactive to proactive healthcare, right? And we also talk a lot about going from episodic to continuous, rather than, having the diagnosis of hypertension all year round, but seeing your doctor twice, to actually measuring your blood pressure all year round and getting either ambient feedback, right, or programmed feedback, or touch points with the doctor, depending on what needed to happen. But when we talk about where that data is going to go and who's going to be responsible, like, I would love someone to look at the phrase digital exhaust, right? I'm putting out data all the time. My iPhone knows more about me and my balance currently than, I've ever wanted it to know. That's what I learned this morning. It was like, are you off balance? I was like, really? This is what you're asking me? So
your iPhone does that to you?
My iPhone, no, there's all sorts of things out there, right? And I love that Daniel wears multiple rings, because each one, is telling it. And this is how we experience what, is happening through this digital data. But whose responsibility is it going to be, Daniel? Who's going to know what my baseline is? Because everybody wants my data, right? So the watch wants to have it, and my cardiologist might have it, but there's this new great stethoscope that might have some, and then there's my ring. Who's going to pull all this together? Are we going to do it at the governmental level? Is it going to be smart people like you, leaning on others to say, let's all do it together? What does that look like? Because right now it just looks like a lot of people.
Yeah. I think some of the responsibility lies to each of us as individual consumers, patients, empowered, whatever term you want to use, humans. Because I don't think you want, as my cardiologist, to feel liable for every alive core EKG I send, or every time I say I'm off balance to send a note to my neurologist if I have one. That creates all sorts of liability and other challenges. I think the better element is if we can sort of become, the overused term, the co-pilot of our care, CEOs, to not have the data, but the feel we're a bit responsible. And I use that in partnership with our care teams, but not to sort of hand over responsibility that someone's always watching my digital check engine light. I think that's a bit of overkill, and that will kill the innovation if we're stifling. It's always the privacy concerns, which I think HIPAA and other rules need to be reinvented in this digital age. But I think the opportunity is for us to hopefully own our data, be able to share it when we want to, but hopefully glean those insights in ways that match us. You might need a different UI and user interface than I would. And right now there's still pretty much one size fits all, not some age, culture, language, or other elements. So I don't have the exact answer, but I think as we now stack things up, not just our digital exhaust, but our base genome and our microbiome and our exposome and our sociome and interactome, all those elements, when we start to apply smart machine learning AI, can truly give us much better insights that really match the individual, or for our patients. And ideally, there's a filter for that. Like if you've got for a primary care physician, and you have 2,000 patients, you want to see on your dashboard the 5 patients. Mrs. Jones' blood pressure is 20 points over normal. Maybe we need to give her a call and adjust her beta blocker. So I think there's gradations to it, but no one should truly feel like it's owned by somebody else, or that, but also, or think that we can only use one data stream to make sense of this.
Yeah, no, that's great. And Jayanthi Narasimhan, Jayanthi, thank you for watching. Is asking who really owns the data.
I think mine and other folks' concept is that we each should own our data, but have easy ways to press the share button. I think I overuse this example, but I'll do it again, is that, 15 years ago, some of us still remember driving without Google Maps or Waze, and now we couldn't imagine driving even across town without sort of sharing private information or speed and location. And that could be, where are you at 2 in the morning? Your phone knows. But in exchange, we get hyper-local information that's relevant to us. I don't care about the traffic in Boston right now, but I think if we bring that idea of, anonymized, crowdsourced health and medicine and learn from other patients' journeys, other patients like me or patients like mine, we can really drive a much smarter healthcare system. My favorite example is actually an Israeli company started by one of the founders of Waze called Stealth, which enables anyone, anonymously or not, to share what their migraine pathway has been, or IBD, or cancer, or I had plantar fasciitis. I found a plantar fasciitis community, what worked and what didn't work. And as you get thousands of folks sharing that information using machine learning and AI to narrow that down, you can get individual insights for your journey, whether that's for COVID, long COVID, plantar fasciitis, or Crohn's disease. So I think it gets interesting when we can optimally share and not be so siloed and, worried about privacy at every step of the way.
No, it's a great point. It's a great point. There's a couple other questions that are coming in directly to me, and people are saying, you saw this coming, Dr. Kraft. What do you see coming next that other people aren't seeing right now? So yes, we're all seeing, we'll use the data, we'll analyze, we'll pick up the key things. Eventually we'll, have markers and triggers. What's the thing we're not seeing? What's the thing we're not seeing that you think might come? And we won't hold you to it. We're not gonna replay this on NBC tonight.
Or while you think about it, I have this specific question because I worked the ER yesterday and I chatted with Ajay. Hi, Ajay, the radiologist, and he's like, "Oh, what's Dr. Joe gonna ask me today?" I was like, "Hey, did you see we got the first CE marked AI radiology read that just completely bypasses the radiologist?" So yeah, no, this is interesting, right? Because there's been a lot of pushback and there's been a lot of nice clinical decision support. Physicians love, clinicians, we all love clinical decision support. Gather the data, present it in a nice, pretty way, give us some tough choices, but ultimately kind of let us decide. First ever, I think it was last week, AI approved, machine does the read of the radiology chest x-ray, and if it's completely normal, nothing's flagged, completely bypasses the radiologist and sends out the read to the patient, which is in doctor world pretty scary for us. So I asked the radiologist who I was chatting with about another patient. I was like, "Hey, by the way, we're bypassing you. How do you feel?" And I thought he might get excited, but he wasn't.
you go right to that third rail sometimes, don't you, Dr. Joe? All right, Dr. Kraft, it is all you.
He called me. I put in the consult and I said, "I need this read," and then he called me. That's what happens when you call me.
Well, that's a good example, a bit of, we all know about, Moore's Law and Exponentials, things changing. Actually, 10, 11 years ago, I gave this TED Talk, The Future of Medicine. There's an app for that. And a lot of what I predicted has sort of come true. And I wrote a little article on LinkedIn, 10 years back and 5 years later, and then what's going to come 10 years from now. So what are we not seeing? And I like the framing. That's actually a misquote of Bill Gates. We tend to overestimate what can happen in a year or two and underestimate what can happen in a decade. There's also something called a Mara's Law. Again, like when we saw the first AI, like Watson come out, it was kind of overhyped, more money on marketing than actually technology. And we thought, oh, in 3 years we'll have AI doctors. But now, a decade later, since it beat Watson, we're seeing platforms like you see come out with CE marks that are really, and we say everything starts to happen slow, then fast. That's kind of the exponential. And now that some of the alignments are coming with reimbursement, regulatory, and some of the COVID catalysts, a lot of those dots are starting to connect. And so I think the next 10 years will make the last 10 years look slow. And so what are we not seeing, or what might be coming next? I think, part of the challenge of synthesis, of taking this multi-omics element and building that real digital twin that will truly be actionable and something that can translate to the patient, to the parent, to the clinician, to public health, and really start to connect those dots in more of that sort of hive mind manner. The problem is we don't have one healthcare system and they're all very fragmented, and I think that means systems like NHS or platforms out of Israel might trump what we can do here in the United States first. And it'll leave us from where we are, still sort of the average patient based on 10-year double-blinded placebo-controlled trials on a very narrow control group, to one that's kind of updated trials that are continuously living through the cloud, that when you have a decision support element, it's not just based on some Framingham trial from 20 years ago. It's updated immediately from, crowdsourced Epic data from Mass General to what's happening in Kaiser in San Francisco. So that's some of where we might be going. Lots of challenges, but lots of potential.
I love that. One question that comes up whenever we talk about this idea of the digital twin, and it comes up a lot actually when we talk about precision medicine and genomics, not just the digital twin, but really thinking about the comprehensive twin, right? Like, can you create based on your social determinants of health, based on your genome, your proteome, if you want to do microbiome, you can add that, and your digital footprint. What is happening is, will we really be able to then take that twin of yours, whatever you want to call that comprehensive twin, and say, if I do this to you, you will feel better in this way. If I treat you like this will change. I probably only need to monitor you this often for this disease, whereas Dr. Joe over here needs to be monitored even more often, but Dr. Kraft less often. And what you're saying makes me think that is possible at some point in this lifetime, perhaps, although it may be more than the 10-year mark that we're looking at.
Right. I think part of the challenge is to optimize what's the end state we want in, let's say, a decade. We all know a lot of the pain points, and we're still using fax machines and CD-ROMs. What would that end state look like, and how do we architect that sort of data flow and workflow and incentive model to get there? A lot of it, technology does not need to be new or invented. We have a lot of dots to connect today. One challenge I see, and you guys are like as on top of it as any, but there's a lot of technology and platforms in digital health that many clinicians have no clue about. So I'm always asked, what wearable's best, what digital stethoscope, what app for this disease management. So I don't have the right answer. So I was lucky to get the domain digital.health, which is easy to remember. And we've been building sort of the ultimate digital health formulary. If anyone wants to try the new version, which will launch in a month or so, beta.digital.health. And the password is just spelled out digital.health, all lowercase. And you can see we have 1,000 solutions in there. That part of this future will be that clinician, your computer decision support might recommend an app to manage stress and anxiety, and a CGM and a wearable device. And you might then be able to prescribe those, have those covered by your insurance company. And then the data flows back to you as the clinician in a way that's not overwhelming or requiring you to log in at 10 different elements. But a start is to sort of build that digital health solutions formulary, and that's what we're sort of doing at digital.health. So anyone wants to join me on that journey, go to beta.digital.health and give it a shot.
So I just want to ask some questions around that. So that's congratulations on digital.health. That actually sounds like an expensive URL that you acquired or purchased. Okay, you're just like creative. Like, this is the creative Daniel Kraft mind. You got it for the cheap $19.99.
No, I was helping the .health domain folks, and I said, I'll help you out for sure, but can I have one domain? I should have gotten men's.health and women's.health and global.health. But
Brilliant.
So
the future that I always painted, that it was always something that I wanted, which is, when I go to treat for hypertension, instead of starting and we first 6 months of hypertension treatment, you're like diet and exercise. And I say that no one knows what it means. And I don't really know what it means because everyone does it differently. But if I could prescribe like a dedicated like diet and exercise app that we know has data on it, I can just do a one click, the information goes to the patient, or they can click and download the app. And then we also know if it's covered. That was kind of like my future. I haven't seen that that I've seen in the US, with the exception that the VA actually in the last 5 years rolled out our own app store for our vets. And we have a fair amount of mental health apps. So what does the digital.health domain look at? Like, you're going to review it. How good are they from a certain perspective? And also, does a payer like Blue Cross Blue Shield actually pay for it? Is that what the concept is?
The end view is that it would be, covered by certain payers. You can see in Germany now, there's DIGA, which is like 17 different apps that are now reimbursed. It hasn't been on yet, but it's on and it's being utilized, but not at its potential. We'll soon have, we have a whole set of now FDA approved apps, whether it's for ADHD or some around diabetes, et cetera, and mental health, that will get covered, and you'll need to have a FDA license to prescribe and will be covered. I think the start is, let's have a matching service. You want to find something that manage AFib, you put in AFib and you can find solutions there. Or, put in mental health and digital.health. You'll see a whole bunch of solutions that may not have been aware of, and find the ones that match your patient. Ideally, we don't want, again, 50 apps or 50 wearables. We want kind of the one app to rule them all, or the wearables that'll integrate across. But I think the big challenge is to enable clinicians to start to prescribe digital health solutions. It's not always an app. Sometimes it's a device. Sometimes it's a combination. Sometimes it might be an element that works with your care team, not patient facing. And part of that is crowdsourcing what works and what doesn't. You can't just rate an app or a wearable on a 1 to 5 scale, right? It might depend on the evidence base and the UI and the battery life and design elements. So the challenge is to hopefully leverage the crowd to help the best solutions rise and enable them to match the patients as we go.
That's really fascinating. Yes.
Oh, all right. We have Martha Pruitt. Martha's an MBA. She says, as a reluctant patient, when I do have a reason to go in, I never feel my doctor has the time to read her own notes, much less has time to incorporate additional digital data points. The data isn't the limiting factor, it seems. That's a great, great comment. Daniel, over to you first, and then Jen, if you have thoughts too.
Direct from a patient. Thank you, Martha.
Yeah.
Go ahead.
Let's reimagine the future clinical interaction. Like instead of the usual like review systems, fill out the clipboard with the 20 questions for what do you have for breakfast or what was going on.
Yeah.
It'll be the download of your wearable device for the last 3 months or year. It'll show that your resting heart rate went from 55 to 65, or that, wow, even your ring today can tell you how you responded to a vaccine booster. So hopefully, we can spend more of the time in that clinical interaction reviewing the synthesis data, the insights, and leveraging that to either behavior change or medication management or app management. Yeah, because the clinician now often spends a lot of time with elements that isn't highest yield. And what's really useful, especially in the future, is not, just the FaceTime, but the human interaction piece, and that patient-doctor relationship or patient-clinician relationship really helps drive the patient engagement and outcomes later. So I'm not sure about answering the question fully, but I can imagine we'll go to a future which is going to be much more synthesized and won't be about the data, but about the long-term insights.
Yeah, this is fantastic. Martha, just before we get into Jayanthi, if you're comfortable, Martha, we would love to, use that quote when thinking and talking to clinicians later, because I think that's one of the parts that the future of medicine holds, which is there is so much information that any one patient walks in with that the human brain in 30 minutes just can't possibly process all those data points to deliver the kind of quality care that we actually have at our fingertips that we could do. And so I think for that reason, your comment is really well taken. As clinicians, we wish people would make it easier and give us all the data and elevate that base of information we have so we can use our clinical acumen on top of that we can connect with you. So I do think that exactly what Dr. Kraft has in mind of how we get the data and what you're trying to say of what we're doing is an area that all groups want to move towards. It's funny when you were talking, Daniel, about kind of the future and what this looks like. One of the things about interacting with patients is you try to give a digital prescription, you don't know how to do it. And there's a lot of virtual first care out there now. There's a lot of virtual first. It gets to areas that doesn't get great healthcare even sometimes. But you do the virtual first, then you say, now what? Now I need to check your blood pressure at home. And I do not know what things are available, which are the best ones for you. Are they in your area? Does it have your language on its monitor? So I think there's a lot of need for what you're working on.
And then the data is always changing. So if Martha shows up with hypertension and she gets one data point or even continuous data from the next generation patch or watch pretty soon, the clinician, maybe prescribe one set of blood pressure meds or 3 of them. How do you adapt that? So what we're developing is to develop what I call intelligent data-driven medicine, where you'll actually sort of 3D print your personalized polypill pill with your dose of beta blocker, ACE inhibitor, calcium channel blocker, which might adapt based on your real-time blood pressures, and might print that in the morning together with your aspirin, your statin, and your antidepressant. And especially when meds need to change, whether it's Coumadin or Lasix, we'll have the ability to really have prescribed not just a med, but an algorithm that'll be adapting to that patient, because there's no hypertension based on numbers every day, and that's what we kind of need to move to in some cases, or other examples.
No, that's so true. And if you could take in if you had a sense of how much salt you were taking in and fluid on the same day you're adjusting your Lasix, right? I mean, what a great thing that would be to be able to take both the meds as well as your environment and combine those two things together in some way, right? Ideally not take a med every day anyway, anymore, by the way, right? Take it 3 times a year and have your blood pressure well controlled, but we'll get there someday.
So I'm just going to put this out there and then we can move to the next question, because we have so many questions today. So the 2 pieces I am obsessed with, and I think it kind of, actually goes to Jayanthi. So thank you so much, Jayanthi, for watching. And also WatchRx was one of the Boston Scientific winners, and it's actually used in hospitals and clinical care settings. Sorry, I just mentored them. I mentor a lot of startups. So love that you guys are interacting with us. But two pieces that I'm obsessed with is, one, how do we take all the technology that we have and spread it out, right? Like empower the patient more, give them data that they can act on. They can learn from the physician, and they can learn kind of what they're supposed to be doing. So that allows them to take ownership, but also spread it around the team. So we have more of a kind of team environment with the physicians, extended providers like nurse practitioners, PAs. My big obsession recently is how to get that out to rural areas, because of everyone knows my care with my mom has been difficult, and the way that medicine is practiced around the country is, I think we just need a lot more cross collaboration, and also caregivers. So I've been a caregiver. So how do we really, because I think caregivers could do a lot of kind of what feels like falls onto the shoulders of the physician. So how do we actually bring them all in to empower the patient and the patient team? But Jayanthi, you have a great question. Went to your PCP, and I agree. The EHRs are big, clunky. They're getting old, and it's hard for us to scroll through the data. So I'd love to hear from Dr. Kraft or Dr. Bhatt, and specifically because Dr. Bhatt has said a few times. So it used to be that everyone was obsessed with integrating all of the data flows into the EHRs, and doctors were all cranky. And we're like, we're cranky. If you don't integrate it into the EHR, we're not going to look at it. So everyone's like, got to integrate it into the EHR. And that was difficult for a number of reasons. And one of the reasons is that EHRs are excited about sending data out. But Dr. Bhatt has most recently said, hey, this data is so valuable now, I don't need it to necessarily go through my EHR. I can work around it. What are your thoughts on the current EHRs and the data streams that flow around it now?
I just want to point out that, Daniel, as we're asking you this question, what Dr. Joe is doing is revealing my journey from not seeing the light, publicly for everybody, as she now asks you this question. I just want everybody to be very clear on what happened right there. But it is a journey. It is a journey, and sometimes you think there's a certain way to do things, and you have to be open to, maybe that's not going to be the way. We have to pivot, and we have to go with the flow. So sorry. Okay. With that having been said, Dr. Kraft, your thoughts.
Well, it is still a bit about the workflow and building much better UIs. We are entering not just a lot of buzz around the metaverse. I like to call it the Mediverse, MED, Metaverse, trademark.
Wait, Metaverse.Health?
No, I get that. But
costs too much now.
What if we completely reimagine like the workflow journey? I mean, it will be that you'll have pretty soon the augmented reality glasses, and you'll pull down the 3D echocardiogram and show that to the patient as well. And also, by the way, in terms of patient education, when you can show them their own heart or a version of their kidneys, what's happening with hypertension if they're not controlling it, that totally changes behavior. Sort of seeing your digital twin in some form. So prescribing medical education and using these new tools. So ideally now we'll have UIs and workflows and the EMRs of the future that are truly leveraging some of these elements. They even sort of had a HoloLens visit of doctors to the space station recently. So how we interact is going to go well beyond physical or screen to sort of this blended realm. And that hopefully can come to our sort of EMRs and EHRs as well. And of course, there's NLP now that can take your visit and compress it and write the note for you. All things happening in GPT-3 and beyond are really going to be quite trippy. I was just at the TED conference, and I didn't see the most exciting technology wasn't one that could recapitulate, a video of somebody, but voice. And so we'll have the Dr. Bhatt avatar show up as your cardiologist in your AI glasses or AR glasses, and so visits can become much more than what we expect on a screen or in a clinic room. So lots of opportunity there.
Jen, we're going to have to go back to having some AR, VR guys. Do you remember when they did the hologram of us during one of our first shows during COVID? We're going to have to go back to some of those. I miss them. They've come a long way in the past 2 years. We should get back to a little augmented reality. More questions, Jen, there?
I think we've hit all of the current questions. I'd love to at least on LinkedIn, and that's the feed it's a technology thing. So I am seeing some Twitter questions, and one of the Twitter questions, great question is, what has been the most disappointing over the last few years? Like what are technologies, Dr. Kraft, that you're like, I was all excited about this, thought we'd be there, and we kind of went in the wrong direction there?
Well, not always that wrong direction, but sometimes the process of medicine is still so inculcated in the past. When I was visiting MGH, I don't know, a year ago. I always go to the White 9 ward where I was an intern 20 plus years ago, and it's almost
Yes.
exactly the same. Maybe flat screens, but the same exact, how rounds are done, how the data is delivered, and now you have some mobile, push a card around instead of a paper charts, which we used to have. And I also rounded recently with a team in internal medicine at a good Kaiser. And it's just like, you're not really integrating all the world's knowledge. You're still have little cards with scribbled information. Should we discharge this patient or not? It's based on the attending's experience or the last 3 patients. There just seems so much opportunity to really pull together the world's knowledge in a much more integrated way that will drive much better outcomes and, public health and prevention and diagnostics before someone ever ends up in the ER. So it seems like we still practice incremental medicine more than exponential. And of course, COVID has accelerated some things. Hopefully we can take that sort of mindset and really accelerate us into a true health age instead of just sort of the, bumbling along. And a part of that, of course, is culture, right? It's not about technology. It's about mindset. There's an old quote from Maynard Keynes. The challenge is not the new ideas, but breaking out from the old ones. And a lot of that is more challenging than technology. And of course, incentives and regulatory play a role there too. So sometimes it's been disappointing, but again, I think we have the potential for the next few years to really make the magic happen if we, align the right leadership and the right incentives and connect the dots.
Yeah, I'm going to reiterate just what you said about culture change. So I was rounding as well this morning, and I had 2 fellows with me. One's an advanced fellow in adult congenital heart disease, and one was a general cardiology fellow. And as we were seeing the patients, we did the general education. In fact, we were in the white building, walking around and talking. And as we left one of the floors, I said, by the way, wouldn't it be great if right now we had the guidelines for this, the most recent knowledge that was out there that popped up, as well as this patient's kind of tracking of what they'd been doing in the previous days before they came into the hospital, because they stated that they had a wearable. And we could put all that data together in addition to the thinking that we just did at the bedside. And they both just looked at me and I was like, I think we would be better clinicians. And it's not to say that we're not good clinicians, but I think you have to say these things out loud. And we have to admit that there is room for growth and room for improvement, and we're doing a great job. And we sometimes don't say it enough. So I would encourage all those, because I can see some of my friends watching who are attending physicians themselves. I think saying where we think things could be different, could be better, and where we say what was wonderful, sitting on the edge of someone's bed today and holding their hand, can't be replaced. Ehrs not going to do it. It's not going to be the same. But I think we find a balance of when is which one necessary, but it has to be there.
100%. I mean, just that mindset that your fellows maybe thought that was a crazy idea. I mean, the patient already has a wearable device. Bring your own device, send them home, and there's some nice data. Even with a patient post total hip replacement or post COVID, watching their steps. Are they walking more or less after their total hip replacement or after the COVID thing? That can just be a small data point that can enable you to be much more proactive before they get readmitted. So a lot of it is about aligning, the existing tech and mindsets. And that's why I put Digital.Health together, because it's not about reinventing new things. It's about even leveraging what we have today and getting those utilized. So for the clinicians listening, there are probably solutions out there that might match the pain points you're seeing. It's up to all of us to start trying them. They may not be perfect. They may not be paid for, but you can start to get those integrated in. Maybe it's connected blood pressure cuffs for your cardiology clinic that aren't being paid for yet, but can really help you manage hypertension in a smarter way.
So maybe, since you said paid for twice in one sentence, and this comes up, I'm going to poke at that a little. So we talked about Germany, we talked about NHS. I was just in Canada recently, and there are places where you have more kind of universal looking care where things, do get in and get paid for. We're not doing a bad job here in the States, but moving forward, what do you see as the path? Because it's not randomized controlled trials of different digital health apps. That's not going to be the way to do it. How will we get the right data for the agencies to start to support and then eventually pay for this?
Well, I mean, I'm not a health economist, but still this, value-based care, outcomes being the new incomes. One good example I know well, I'm on the board of an Israeli company called Healthy.io. They've developed the ability to use your smartphone to do urinalysis and wound care, and a great opportunity. We're talking to a renal doc here as well, is, to screen people for...
It's all in the urine. Yeah, the urine will tell you everything. If you would just look at the urine more, it actually tells a lot. Yeah,
it does a lot. It does a lot. Yep.
but we have like only 10% of patients with early chronic kidney disease know they have it. And now you can screen for albumin and creatinine and protein in your urine with a simple, dip your urine, take a picture of your smartphone and have that instantly. And that can make a huge difference in preventing downstream transplants and dialysis. So, that's a no-brainer, and it's starting, NHS has picked up on it. It's starting to roll out with some of the Blues plans. That's a great example of where a digital tool can replace the old analog module. And I think a lot of us try to innovate by taking the fax machine and digitizing it. Sometimes we can do things completely differently, and that will move the needle. And particularly if we move from sick care to healthcare and leverage these tools for early prevention, early diagnostics. There's so many ways now with voice and our wearables and our Internet of Medical Things to pick up disease at stage 0, stage 1, before the heart attack, stroke, late stage cancer. It can be voice as a biomarker, the sound of your cough, the AI camera on your phone that can pick up your O2 statin blood pressure, or yellowing of an eye. I mean, a lot of potential there to move the needle to the left that will give us more dollars to spend on the true sick care side and innovate.
It's such a good point. We've been talking a lot about maternal mortality and what a big problem it is internationally, but really nationally in the US, out of the developed countries, where the one group is kind of doing the worst on it. And cardiovascular disease, is part of that. So we take part of the blame. California's done a great job. And there's a new company that came out with a urine test. To your point, urine can tell everything for preeclampsia in the first trimester, right? And so those kind of places I agreed in. When we make the point that the outcome is just so worth it, that the potential change in that outcome and the value of that mom and that baby's life, right? What a difference we make. I will tell you something fun, which is earbuds. Jen, I don't know if you were with me for this conversation, but the earbuds that we put in our ears to listen to things can now actually differentiate and hear the sound of your blood flowing in your body, and be able to tell you things about valve disease and more, just from having earbuds in your ears. And so how interesting to take what you do in daily life. And it's what you said, Dr. Kraft, when we are thinking about transforming medicine, we say, well, how do I take what I'm doing now and suddenly make it, modern and innovative? And sometimes it's, no, what am I doing all the time now that I can use that has a great technology that may give me some information? So I love that idea of thinking about it that way.
And a lot of the best ideas I find, so I just recently co-founded a early stage digital health focused venture fund. So if you have any deals sent in my way, Continue Health Ventures. A lot of the coolest companies and ideas come from people who are not traditional doctors or biopharma folks. There are video gamers or AI folks, or come from completely different fields. But then of course, then they need to integrate with the clinicians and really understand the unmet need from all the other angles. But there's a lot of great folks outside the usual four walls that are innovating in the space, and that's the most exciting, when you could have blend all these convergent technologies and new sort of mindsets together to solve the big pain points.
No, absolutely. All right, we probably have time for a question or two more. Mark Formison, thank you, Mark, for writing in. Mark says, how much does it matter what we can do with digital technology unless we agree on what we should be doing? Your example of urine screening begs the question, how often should this be done? Do we know daily, monthly? What information are we looking to acquire? It's a great question, Mark. Dan, I'll turn it to you first, and Jen, maybe if you want to.
Not being the nephrologist, I believe at least, once, if you're diabetic or a hypertension patient, you should screen your urine at least once a year. And that's not happening for like 80% of the patients. They're not bringing their urine to the lab. It's not happening. So in those cases, of course, there are going to be smart connected toilets to do ins and outs. Those are already evolving. But I don't think we need every day. A lot of things can be done, once a quarter or once a year. And they are getting cheaper and more digitally more available. So it doesn't also need to be always perfect. We saw in the pandemic with the FDA, super slow on approving new diagnostics. I've been chairing this XPRIZE Pandemic Alliance Task Force. We ran a $6 million XPRIZE for fast, frequent, cheap, and easy COVID testing. A lot of that is because the FDA wanted the equivalent of a PCR test for your home diagnostic for screening. So some of these things don't always need to be perfect, but they can move the needle, because perfection may be the enemy of the good, particularly for early detection and that early first pass at screening.
Yeah, I think those two key points, Mark, for you are, one is for the things that we have an analog version that we already have guidelines for. This is how often you should check. Then being able to have that, and patient agency to do it at your fingertips. I think that's one first place. I think what you're getting at, Mark, though, is some of these things, like let's say you have a
screening.
let's say you have anything else. Check my lungs, check my kidneys. Why don't I do it every day? And I will tell you, health-related anxiety was a problem before in our society and has gone through through the roof since COVID. And so we also don't want to constantly be checking everything about ourselves and not actually living life. So your point's well taken. I think we need to take the guidelines, take the things we know about the frequency, and you'd be surprised the number of people where we know that someone should be checking for blank because they have risk, and they just don't get to it because life is busy. And so if we could even capture half of those people, we would probably capture a lot of disease earlier. And so I think those are the populations we kind of aim for first, while being conscious that you don't want to constantly be checking everything. Sometimes you actually want to disconnect too.
Yeah, in a sense, you don't always want to be checking. You want to hopefully get that smart nudge that, like my Whoop, for example. Hopefully you can hear me. AI is easy, AV is hard. Hopefully you can hear me. Like my Whoop now kind of has a bit of that check engine light. It looks at my sleep, my HRV, my resting heart rate, and can kind of tell me when I really need to take it easy that day, or it could potentially be waving that red flag of, something's really off.
That's exactly right. Finding those triggers, right? Those, knowing that you're kind of being monitored in the background, being okay with the privacy related to it. But again, there's so many things we do where we give away privacy for less benefit. And then being able to just be told when something may not be right. By the way, by our next show, the audience should really ask Jen and I how many different things we're wearing. There's going to be rings, bracelets, whoops. We're going to have like necklaces. It's going to be great. We're going to have a competition, Jen. Who can wear more?
Oh, really? We know who's going to win. So, this has been such a great conversation. We have gone over, Dr. Bhatt. Are we?
Oh my goodness, we have. I didn't even realize that. That was delightful, though. Dr. Kraft, this has been such a pleasure. Just watching you lead this, and you say it humbly, but I will tell our audience. Dr. Daniel Kraft predicted a lot of the things that we have today many years ago, and knew that we could get there. So it's really exciting, and that's why I ask him about forward predictions, and so do others who know him, because we're looking forward to where we go. But maybe let's give you the last word, Daniel. Final thoughts that you want our audience of clinicians and entrepreneurs and VCs and engineers and patients to hear.
I guess the first, thanks for having me. This was fun. I think final word would be that, realize that the future is coming faster than we might think, that we all can solve pain points and problems, especially collaboratively. I mean, I can't program, but I have friends who program or can 3D print or know AI chatbots. So you can connect a lot of dots now that we didn't have available, 10 years ago or 20 years ago. I try and look at the future through a sort of convergent exponential lens. My Exponential Medicine conference, we're rebooting and rebranding that, and it'll be launched early next year. So if you want to follow me along at danielcraftmd.net, you can sign up for my newsletter, and we'll hopefully keep you apprised on what's happening, or Twitter, Daniel_Kraft, and hopefully I'll tweet things that are forward. The future's up to all of us, and I think we sometimes want to outsource that to, those innovators over there. And I think, we can all kind of collaborate better to solve for our local and global challenges.
Oh, it's wonderful. And so well said, right? Each of us is an innovator, and we just have to believe that. Jen, final word off to you.
Yeah, very excited. Dr. Kraft, thanks for coming on the show. Really delighted and excited about all your endeavors. Dr. Bhatt, great job leading the 60,000 plus cardiologists that you had come together. And as always, really appreciate our audience of physicians, entrepreneurs, people who believe that the world can be better through technology and thinking about how to solve some of the big problems. So thank you for joining us today. And thank you to Dr. Kraft and Dr. Bhatt. Bye-bye.
Bye.